What is the cost of the coarctoplasty?
Good morning, everyone. I am myself Dr. Lino, second year PG registered in Department of General Medicine. I am presenting on behalf of Medicine 2. So this is regarding Mr. X, who is a 20 years old matchbox factory worker from Vellu, presented to our emergency department on 18th of this month. He presented with abdominal pain for 3 days, which is diffuse pain, non-radiating, no aggravating or relieving factor. Associated with the abdominal pain, he also had vomiting for 3 days, multiple episodes, non-bilious, non-projectile, and no blood in vomitus. In addition to that, he gave history of loose stools for 3 days, small volume, multiple episodes of watery loose stools. He's been treated outside in GH for this syndrome complex of acute gastroenteritis. However, there is no improvement in symptoms, and on 18th, he presented to our emergency department. And interestingly, after presenting to our emergency department, he gave a new history of self-ingestion of potassium dichromate crystals of 30 gram mixed with almost 500 ml of water, and he consumed a total of 300 ml of the compound. So with this background history, I want to post a spotter. And so what can you make out from this X-ray? So there is air tracking along the neck muscles. There is air shadows along the heart borders, and there is switches of subcutaneous emphysema. So at the presentation is respiratory. This HS
is a pneumomediastinum.
Yes.
Okay.
So at presentation, his respiratory rate was 18, pulse rate was 100/60, pulse rate was 104, and he was conscious oriented to time, place, and person. Significant examination finding we noted as a crepitus over left supraclavicular region. So his baseline investigation showed total counts of 16,000 with neutrophils of 80%. His
the question here on clinical, when you see this patient in casualty with pneumomediastinum and with this history, what are your thoughts? Why has he developed a pneumomediastinum?
So perforation, esophageal perforation.
Esophageal rupture, yeah.
So esophageal rupture secondary to the potassium dichromate ingestion. That's your clinical diagnosis. Go ahead.
With a SGOT, SGPT of 84 and 45, his INR presentation was 2.12. So something about potassium dichromate poisoning is it's a corrosive agent. Normal lethal dose is up to 1 gram. Our patient consumed almost 3 grams with 500 ml of water. Mainly it's eliminated via kidneys, and it causes injury to kidneys and hepatocytes via free radical mediated mitochondrial injury. So there is phases of damage that potassium dichromate causes. In the early phase, it causes GA symptoms. Most likely our patient has presented with abdominal pain, vomiting, and loose stools. And in late phases, it can cause renal injury, either secondary to direct toxin effect in the tubules and volume loss, and it causes hepatic injury. So today I will be focusing on approach to corrosive poisoning, which will be less in our clinical practice. So the amount of corrosive poisoning, the amount and extent of corrosive poisoning damage can be based on based on the nature of the toxin and its physical form and corrosive. Most likely either it can be acid or alkali. When it is acids, it can cause coagulatory necrosis. Because of this coagulum, the incidence of full thickness injury is very low. However, when it is alkali, it causes liquefactive necrosis, and there is a risk of perforation is very high in alkali poisoning. There is an old dictum that states acid licks the esophagus and bites the stomach, but that's not more common anymore. In recent past, we were seeing most acids also causing esophageal perforation, which we see in our case. Our patient had esophageal perforation. So what are the clinic? As soon as you see a patient with corrosive poisoning in emergency department, these are the alarming symptoms to suggest severe poisoning. One is odinophagia or dysphagia, and stridor or hoarseness of voice causing pharynx or laryngeal injury secondary to the acid poisoning. And if patient has a respiratory distress with the tachycardia and drooling of saliva, again that suggests a severe poisoning. And if patient has abdominal tenderness or peritonitis, that is also suggestive of gastric perforation. So these are the warning signs that has to be addressed when we see the patient initially. So what are the basic evaluation in addition to a routine investigation in a patient with corrosive poisoning is chest X-ray, which we most of the time neglect. As a chest X-ray is a very small investigation, but we should always focus in chest X-ray patient with corrosive poisoning. These are various signs that we see in X-ray to suggest pneumomediastinum. One is Neclario V sign that is secondary to air borders, air along the lateral border of mediastinum and the medial border of diaphragm, and there is continuous diaphragmatic sign. And if patient presents less than 24 hours, patient should ideally undergo gastroscopy to know the extent of esophageal injury. So, what is the management for potassium dichromate poisoning is basically supportive care. There is no efficacy of activated charcoal has been proven previously. There is some role for ascorbic acid, however, there is no clinical trial to suggest evidence. And there are theoretically, N-acetylcysteine can also help in decreasing the liver injury. However, there is again no clinical trial to suggest the same. So our patient had acute kidney injury with a Bunn-Create ratio of 15, suggesting probable acute intrinsic renal injury, and he had probable probable esophageal perforation with pneumomediastinitis and mediastinum and acute liver injury with coagulopathy. So our patient, we started him on empirical antibiotics because of esophageal perforation. He had fever, presentation, he had fever with tachycardia. We started him on empirical antibiotics with injection of meropenem and antifungal coverage, injection fluconazole. For pneumomediastinum, we have involved gastro team and surgery team. He was hemodynamically stable and he was not in full-blown sepsis because he already had feature suggestive of perforation, gastroscopy of deferred, and surgery because he was hemodynamically stable and there is no signs of sepsis at presentation. Plan was made for conservative management. And when his parameters were improved, plan was to proceed with FJ.
What is that?
So feeding gynostomy plans. So with a conservative management, his hemodynamic, his parameters improved, his AK resolved, his acute liver injury also reversed. So one particular thing I want to highlight: why did we use antifungal therapy in this patient as empirical? So role of empirical antifungal in esophageal perforation. This is a study that showed retrospectively analyzed 27 admissions over a period of 6 years. All patients presented with esophageal perforation, out of which during the course 16 of the patient developed blood culture and pleural fluid culture positive for fungal infection, and the mortality was almost 31% in among those developed this fungal infection. However, there is no randomized controlled trial to suggest evidence of antifungal therapy, empirical antifungal therapy in esophageal perforation.
What is the overall mortality?
Sir?
What is the overall mortality?
Sir, other patients are no mortality.
Did this patient
what
have
is the
hyperkalemia?
Would you repeat the question, sir?
Did this patient have hyperkalemia? He had acute renal injury and he had consumed potassium dichromate.
No, sir. He didn't have hyperkalemia.
Why did he not have hyperkalemia? Hey, vomiting here.
How
He
much
had been
of
vomiting,
potassium?
right? Okay, right. That can put the potassium down. Okay. All right. How did you get this history of ingestion of potassium dichromate? He didn't say that in the other hospital.
Yeah.
Where he went.
He himself told, sir. We didn't have to probe much. He himself.
Was it a suicidal bid? Is that what he tried?
Yes, sir. Yes,
okay,
sir.
So, yeah, I think
so
it's
he had
important
access to it.
Yeah.
He had access to it because he was in the matchbox. So he had access to it. He was going through some psychological problem, and he took the potassium dichromate and presented to you. So when you look at the this other Royal College publication, right, and you said that esophageal perforation is also a systemic fungal infection in 50%. What was the cause of the esophageal perforation in those cases?
It's not only related to corrosive, sir.
So how useful is it to take evidence from some other setting with a different set of conditions? So what is the risk in this particular individual of a systemic fungal infection?
So general risk factors are these patients will be on long-term TPN therapy. Second, they will have a prolonged hospital stay with long lines, and fungal candida can be a normal colonizer.
When you infiltrate esophageal perforation, at what point do you get a systemic fungal infection? Is it in the acute phase or when it's long drawn out, when you're giving TPN and giving a lot of antibiotics, multiple lines?
In long run, sir, when prolonged hospital stay when they're in.
So one should be very careful to take evidence from a different situation and apply it to a very unique problem. Because here in this setting, it would be very difficult to defend the use of prophylactic antifungals in the acute presentation of a corrosive poisoning.
So clinical learning points are clinical examination in corrosive poisoning and chest X-ray findings in corrosive poisoning, and not always not all acid corrosive injuries causes gastric injury. They can even cause esophageal injury. Then role of prophylactic antibiotics.
Thank you, Lino. We'll go on to the last case, Sharon.